Good evening, friends. Welcome to the Tuesday evening academic session from Yashoda Group of Hospitals. We bring some interesting hot topics, debates, and controversies into the platform. And every time we bring a interactive discussion with our all participants. And for a special day today, we have a special discussion that is related to the fourth wave. I think after the second Delta wave, we have been waiting for a third wave, and somewhere we all were fortunate that the third wave in somewhere between January onwards, the case number was gone up, but the number of hospitalizations, the number of mortality and morbidity has seen to be limited. And that was seems to be a milder case. Right now, again, there is a surge in the numbers of cases across the globe, maybe in the many parts of Southeast Asia and some parts of in the West. So that raised a lot of discussion and doubts and debates across many clinicians. I happen to also receive many calls related to those. So we thought of bringing this discussion, and we are fortunate enough that today we have two national expert panelists, Dr. Khilani, who has been the HOD and professor in the Department of Respiratory Medicine, All India Institute of Medical Science, and now he retired and being the chairman of PSRI Hospital in New Delhi. And also we will have Dr. Randeep Guleria, who is the director for All India Institute of Medical Science, who will be joining us soon. So to start with, Dr. Sai Kiran, who is our consultant in critical care medicine from Malakpet Yashoda Hospital, will take us through briefly what this wave's about and why are we having this discussion today. Over to you, Dr. Sai.
Yes. Presentation. Thank you so much, Venkat, sir. A very good evening to our distinguished panelists and a warm welcome to our live audience. I'm Dr. K. Sai Kiran, and over the next 10 minutes, we'll have a brief overview of the pandemic, how it started, how it progressed to the point where we stand today. As the world was bidding goodbye to the year 2019 and preparing with full gusto to welcome 2020, a few collection of pneumonia cases were reported in a remote village of Wuhan, China. And in the initial few days, it was termed coronavirus-induced disease of 2019, that is COVID-19. And in the first few days, little did anyone imagine that over a span of 2 years, this virus would breach all geopolitical boundaries and touch every part of the globe and create one of the most dreadful pandemics this century has seen. In terms of the numbers as we stand as of yesterday, that is May 2nd, globally, there have been more than 51 crore cases that were detected, with the number of deaths being accountable up to 62 lakh cases. In terms of the distribution of cases, a handful of countries, that is the United States, India, Russia, Brazil, and few parts of the Europe, that is the United Kingdom, Germany, and France, make up close to 50% of the entire caseload globally. During the initial days, though there was one single epicenter from where the virus originated and spread to other parts of the world, as it spread to different continents, there were many epigenetic factors and other local factors which helped in the mutation of the virus, and that led to creation of variants. And each individual region then acted as an epicenter of its own, and that has led to this global pandemic. And after a certain point of time, it becomes very challenging to trace back to the origin of the virus itself. If you're looking at some of the data that is coming in from the region-wise, you can notice that the Europe and the Americas have been a dominant role in terms of the number of cases that were detected. And if you see this graph, you can see multiple peaks and valleys. And these peaks and valleys are what we call typically the waves. Though there is no universal definition as to what a wave is. It is the period of time when there's an exponential rise in the number of cases over a short period of time. That is, the cases double every day for a few weeks, then followed by a sharp decline to reach a baseline level. And looking at this graph, Europe has gone through more than 3, 4, or up to 5 to 6 waves. Similarly, America has been experiencing a continued surge of cases, and Southeast Asia as well. Looking at India since the outbreak, if you look at the graph since the outbreak, India has gone through 3 significant waves. The first one caused by the Alpha variant around September and October of the year 2020. The second wave being the caused by the Delta variant around April and May of 2021. And the more recent Omicron wave, which has just recently concluded around January and February of 2022. And in terms of the number of deaths, obviously the Delta wave that we've experienced last year has been the most deadly. It has been a period of time which many Indians may never be able to forget in their life. But as we begin to settle and as we were beginning to relax and probably experience a sense of normalcy, we begin to hear that the India is probably on the cusp of a fourth wave. Why do we hear such things? The main reason is the data coming in from our neighboring Southeast Asian regions, that is China, Hong Kong, and South Korea, which have witnessed a significant spike in the number of cases over the last month, a month and a half. If you can see here, China from 2nd April onwards, the cases have been gradually rising. Hong Kong has experienced a sharp spike. Even South Korea has experienced a sharp rise in cases. But going by the data coming from those countries, the spike in these cases or China, Hong Kong, and South Korea have been mainly attributed to the Omicron variant of the COVID-19. The reassuring part to India is that India has already gone through the Omicron variant. So will this not have a significant bearing on the wave in India? Also, there has been a certain surge in numbers in parts of Europe, mainly Germany and UK, where even after the Omicron variant, they have experienced a slight surge in the cases. Part of it is due to the BA.2 variant of the Omicron, which also India has experienced because there were detected BA.2 variants of Omicron during the third wave of India. And another important reason for the surge in cases of Europe is the complete lifting of the COVID-19 protocols with voluntary mask policy and other policies, which probably could have attributed to a rise in cases. This again graph shows the surge in cases in the Southeast Asian region, that is China, Hong Kong. Coming to India's data over the last couple of weeks. In the beginning of April, when the daily average cases was less than 1,000 in the first week of April, India has witnessed this gradual rise in cases, and the current 7-day moving average is around 1,500. And the bulk of these cases are coming from Delhi, Haryana region. Delhi, which was recording only about 400 cases per day prior to 18th of April, is now recording close to 1,500 to 1,600 cases per day. Similarly, Haryana. But a similar trend has not yet been observed in the southern part of India, states such as Karnataka and Telangana. And whether the rise in the number of cases in Delhi is significant enough to predict a fourth wave, one of the additional director generals of ICMR was quoted saying that the rise in cases in Delhi is probably due to a blip and does not necessarily reflect the onset of a wave. And he said probably this blip is attributed to the local factors. When we talk of local factors, if you look at the graph of Southeast Asia and China, Hong Kong, and South Korea, which are prominent contributors to Southeast Asia, let's compare the graph. The Southeast Asia graph, definitely you can appreciate at least 3 to 4 waves. But when we look at the graphs of China, Hong Kong, and South Korea, after the initial wave in the beginning of January 2020, they have hardly witnessed any surge in cases until the last 1 month. So practically, they are probably experiencing only the second wave of the pandemic. This goes to show the regional variation. Even within a similar region, different countries may be experiencing a different wave. Even looking at our own data, traditionally, we have seen that India has gone through 3 significant waves. But let's look at data of Delhi since the outbreak of the virus. If you can see this graph, Delhi has at least seen 5 instances whereas there has been a spike in the number of cases. And not all of them have translated into waves at a national level. So is this blip really contributing to another wave? It is important to know because it determines our level of preparedness at the hospital level, at a society level, the medical infrastructure that needs to be ready. Because we've seen that the amount of information that we had during the arrival of Omicron we were better prepared. Though the fact that the Omicron was a less virulent variant, we were better able to handle that wave. Secondly, we should shape our SOPs and policies in such a way that we can mitigate any kind of distress the virus may pose on the system. Also, it may give us a rethink on whether we can relax the COVID protocols yet, or is there some more time for that? And there is a recent IIT Kanpur study which predicted clearly the onset of a fourth wave, which is set to begin at around June 22nd, peak around August 23rd, and probably decline by October 23rd. In order to make such prediction, there are multiple factors that need to be taken into account. Most importantly, the vaccine status of our country. India has had one of the most robust vaccination programs. Close to 189 crore vaccines were administered, and close to 62.3% of the population is fully vaccinated. Apart from the immunity derived from vaccines, our country itself has had a large immunity received through natural infections as well. Also, the demography has to be considered. Some of the areas that are having a spike in cases have an aging demography, while India is a more predominant young population. And the other important factor in determining whether a wave would arrive is the possibility of a new variant, such as the recently in news XE variant, which is a hybrid of the BA.1 and the BA.2. And there are few reports saying that the XE variant also has been detected in India. And most importantly, the local factors. As you've seen earlier, a spike in cases in a certain region may be due to behaviors of that particular region, certain high-risk behaviors which tend to spread the pandemic, and many other factors which are local to that area only. Given that to predict a wave, there are so many dynamic variables, and an interplay between these dynamic variables ultimately leads to the prediction of a wave. Can we make a statistical prediction, or is this an intellectual guesswork that is going on? To shed more light on this, I would like to hand over to our distinguished panelists.
Thank you, Dr. Sai, in bringing that front and forward. So to start the discussion rolling, we have Dr. Khilani sir, who has been for the last 2 years of pandemic. He's on the front line in many of these expert panelists and giving his expert opinion, and not just in the COVID, but in the many respiratory related illness, public awareness programs, and many more. So we also invite Dr. Randeep Guleria, sir. Sir, can you switch on your, so welcome you on board, sir. Randeep, sir, can you switch on your camera, please? Yeah, thank you for joining us. We welcome Dr. Randeep Guleria, sir, who has been one of the frontline panelists for many of us, guiding throughout the nation in different situations. He's been the director for All India Institute of Medical Science. So welcome you on board, sir. Sure, your mic is muted, sir.
Thank you very much. Thank you.
So thank you on board. And Dr. Sai had just brushed us through the last 10 minutes related to this last couple of years, all the waves related issues. So what exactly happened is, with the current rise of the cases across the different parts of the world, from Southeast Asia and some of the Western countries like UK and Germany, there is again a little, you may say, apprehension. There is some kind of concerns related to many clinicians. And there is some complacency also, because the last Omicron wave was relatively milder. There was a relative lesser hospital admission, relative less mortality related. So the first question is, so we are all getting through different prediction models across the, right now, across the India. We have seen the recently in the February, IIT Kanpur, a set of team members actually released a prediction model. To start with, Dr. Khilani sir, what is this prediction model? So we have been seeing these prediction models in the last couple of years, and we lost these prediction models when second wave came. None of us could actually exactly predict, but after that, during the third wave onwards, we have seen a lot of prediction models coming and going. So what are the prediction modeling? What are the role in this pandemic?
The models are actually statistical methods which are very, very scientific, I would say. I'm aware of the IIT Kanpur, which are actually doing modeling for this. You can model immunity of the population. You can model susceptibility, you can model the demography, but what you cannot predict is the variance. And that is the one which has been boggling all of us. And if you see the history of variants, the Delta variant was much more contagious than the Alpha variant. The Alpha variant was much more contagious than the original Wuhan variant. And now the Omicron variant is much more contagious than Delta wave. And now that new variant, which is called Omicron subvariant, which is called BA2121, is supposed to be 25 times more contagious than the original Omicron variant. So when you combine this all, it's very difficult to predict. Although I am aware that Kanpur group has said that by 22nd June we'll start with the fourth wave and it will peak in the August and it will finish in October. Those are good models, but as you said in your, gently said that they have actually not been come to the test of time most of the time. So I would request Dr. Guleria to further comment on this.
Yes, Guleria sir, even this model predicted somewhere in the June, you may see a rise and it may get into peak in August and may end in October. But we all know these are all AI-based models. These are all mathematical models. But there are many challenges and confounding factors like vaccination, like herd immunity, like also the variant, as rightly pointed out by Khilani sir. So with so much of complexity, how these models we can actually consider as this can predict us something?
Thank you for inviting me. At I would agree with what Professor Khilani said, that you have a lot of variables which are present. Now, if you look at modeling is done by a large number of groups. We have the IIT group which does it, the Sutra model. We have a group from UK which does it, and an Indian from the US. She's also doing a modeling as far as this pandemic is concerned. And there have been a lot of variations. Even if you look at the prediction of the second wave, which was driven by the Delta variant, the models were quite inconsistent and were not able to really pinpoint when the peak would happen. And therefore, I think we need to understand that when we're looking at a mathematical model, we factor in a lot and we give weightage to various factors and then try and build that model. But still, there are variables which we cannot take into account. And I think we must understand that when we look at an infection like COVID-19, there are three broad things which have a lot of variables. One is the host, the second is the environment, and the third is the virus itself. All three have a lot of variables. The host, that is humans, have changed a lot as to what we were 2 years ago and what we are right now. As was very well mentioned in the presentation by Dr. Kiran, that we have now a lot of immunity, which is either through vaccination, through natural infection, and we also have hybrid immunity. Many Indians have also got the vaccine and have also suffered from COVID. So we have an immune system which is now sort of primed to the virus, which was not there last year or before that. Second issue is the virus itself. The virus has mutated, and there was a lot of fear when Omicron variant was discovered from South Africa and Botswana, that this, because it had more than 30 mutations at the spike protein, would be more virulent, could be more infectious. And what has been shown is that although it is more infectious, it spreads rapidly, it is not that virulent. It's not able to enter into the alveolar cells, and it usually doesn't attach to the ACE2 receptors that well. It enters the cell more by cleavage rather than going through ACE2 receptors. So the virus is mutated in a manner which suits us in terms of causing a mild upper respiratory infection rather than COVID pneumonia, which we were seeing with the Delta variant, where we had this huge number of patients requiring high flow nasal cannula, non-invasive ventilation, and even intubation and ventilatory support. And the third factor is the environment. And that is another issue, that how do we have behave in terms of COVID appropriate behavior. So these are three variables which are difficult to factor in any, let's say, modeling that we do. And therefore the modeling keeps changing, and people keep saying that we can model for the next 3-4 weeks maximum, and then seeing the trends and seeing what is happening, the model will evolve. So I don't think we can predict, and I think the modeling is going to be difficult. Having said that, I would just like to say that we are in a better position than what we were last year, both because of vaccination, because of immunity. and how the virus has evolved over a period of time. Yet there are a lot of unknowns, especially how the virus will mutate in the future, and therefore we need to be vigilant. But I don't think we can totally rely on the modeling data as of now.
And predicting for so long, maybe beyond 4 5 months with so many confounding will be a bigger challenge.
Correct.
So the next part is not just the case rise in the Southeast Asian part or West. We have seen a surge in the cases, whether it is due to testing, whether it is due to concerns in more of Delhi, Haryana, and some parts of India. And recently, we have seen the deputy director of ICMR also commenting, telling it's a blips more than a wave. So, what's your comment? You being a part of All India Institute and you being closely a part of many of these programs where you being a part of the advisory committee. So, where do you stand right now? What are we seeing?
So what we're seeing, I agree, is it's not a wave if you will to define it in the form of a wave. We're seeing an increasing number of cases, but we're not seeing a wave as per the definition, which even if you look at standard definition, because the number of cases is not that large, we're seeing just a surge in cases. What is fascinating is we're seeing a large number of cases rising in Hong Kong, in South Korea, we've seen it in China and certain parts of the world. In India, what we're seeing is that the blip or the rise in cases is to a large extent in NCR region, in Delhi, Haryana, UP, but we are not seeing that significant rise in other parts of the country. For example, Maharashtra is not reporting a rise. So it's interesting, and that's why I think it's related to some factors which may be mutation and some factors which may be environmental related. But it is interesting that the cases surge is predominantly limited to this pocket rather than other areas. And if you remember in the past, all these waves actually started from Western India and moved towards central and then went to the east and the northeast. We had a huge surge in cases in Maharashtra, in the south, and then we had saw a surge in central part of India. And then later on, it went to West Bengal and the northeast. This time, what we're seeing is a cluster or cases which is happening in Delhi itself and the surrounding areas, which is interesting and needs more clarity. Second important issue that I think we need to understand is that our testing has come down significantly. And therefore, to say that our positivity rate is high may not be correct because we don't know the denominator. Large number of people are not getting tested, even if they have flu-like illness. So sometimes we say our case positivity is 10%, 5%, but that may not be an actual case positivity rate because the testing is not as much as it should be to really give an accurate amount of the positivity rate. So that is the other thing that we need to keep in mind. There was a time when Delhi was doing more than 60,000 tests per day. Now we are doing somewhere around 10 to 12,000, and we've even done on some days less than that, less than only about 8,000 tests a day. So it has gone up a little bit, but we haven't reached that type of testing that we were doing in the past. And therefore, calculating the positivity rate may not be a correct indicator of the number of cases that we're seeing. And of course, there is the severity of illness is not there. We're not seeing a surge in hospital admissions. We have very few cases admitted in our hospital also. And all of them are those who have comorbidities rather than COVID pneumonia.
Khilani sir, you mentioned about the variant which actually had some play in India and in some of the West. But we have not seen the same kind of surge with the Omicron or a Delta, as pointed out by Dr. Sai also, in China or South Korea or all those areas in Hong Kong. Do you think that also has a role to play, that we as a country has gone through a very huge amount of case surge during this to both Delta and Omicron variant? So that will also give some immunity. What I actually trying to point out is in the second wave, Delta, the surge was somewhere between June, July, and August. But later on, when in May, June, and July, but somewhere later we saw Kerala spiking that Delta wave in September, October. But their initial Delta cases during that time, when all over the India we were facing, were less likely. So is it that variant also playing a role that we are seeing a rise in Southeast Asia countries like China or Hong Kong and all that?
Of course, the variant is the main thing. There are three things: agent, host, and environment. Now, I'll compare it to India, and that probably will clarify. India had a severe surge during Delta waves. And everybody believes that although the number of cases which are actually reported are something like 6 crore, but the majority of us feel that more than 90% of Indian population is already infected, whether known or unknown. Over and above, as Dr. Sai has already pointed out, that large proportion of us are vaccinated. The best immunity comes with the combination of natural infection followed by vaccination. This is known. And it is also, there's a paper in JAMA which said that after natural infection, the immunity lasts for at least for 20 months. I strongly feel that that is what is protecting us. Of course, the Omicron and the current variant, whatever is going around in Delhi NCR, is less virulent, more contagious. But also there is a great role of our immunity, which is developed by infection, supported by the robust vaccination program. The US is still seeing deaths every month, which are much more, and of course more in the elderly. And I think these people, the China and all, had the robust program, as we understand, as far as the infection control was concerned, as compared to the India. So my thinking is that these countries have not had natural infection, so their immunity is not as robust as of India. India has seen a catastrophe. And if you take the biggest example was of Dharavi. During the first wave, Dharavi was on the boil. There were so many cases, so many deaths. And when actually the worst wave came, the Delta wave, the Dharavi slum didn't have much cases, 10 to 12 cases per day. That is the reason. So ultimately, it boils down to our community medicine, agent, host, and environment. As far as the host is concerned, we are in a position of advantage. Agent, we have absolutely no control. The environment is determined by our behavior. No denying the fact that India has become very complacent, and so is if you talk about complacency, the worst is United Kingdom. Who never believed in putting on any kind of meaningful restrictions. So currently, the surge in China and Hong Kong is related to their inborn, in the immunity that they have, and that's what I believe. Thank you.
Dr. Randeep sir, now we are seeing a case surge in at least NCR region, and we have seen the change in the clinical profile from Delta to Omicron, and also the system involvement. As you said, it more was milder symptoms, more localized to the upper respiratory tract. But we also see a more tiring, more fatigability, more GI related symptoms in Omicron variant. And now also we have some information that GI upsets and there's a tiring, severe body aches, headaches as being a phenomenon. What was your take on that? Are you seeing any change in the clinical profile during this last surge in the NCR region?
So that's correct. We are seeing patients who are having GI problem, diarrhea as a common symptoms, along with nausea and vomiting. Fatigue, which lasts for much longer than in the past with body aches, headache, is also there. But we're not seeing any fall in oxygen saturation. Hypoxemia is not a major presenting feature, or breathlessness. Most people have an upper respiratory catarrh in the form of fever, sore throat, persisting cough for quite some time. So the symptoms do overlap with what we saw with Omicron, but some of them what we saw with Delta. But what we're seeing predominantly is upper airway involvement, no lower airway involvement, no COVID pneumonia, a lot of generalized symptoms in the form of fatigue, body aches, and a little bit more. I don't have the data to say what percentage it is, but a higher percentage in terms of GI disturbances that we're seeing. The good part is that we are not seeing increase in hospitalization. We are not seeing increase in ICU admissions, and we're not seeing an increase in mortality. So therefore, what we're seeing is a milder illness causing more systemic manifestations, causing more upper airway involvement, and possibly the virus causing some degree of gut inflammation and GI disturbances. So therefore, there are two schools of thought now. How aggressively should we push for COVID appropriate behavior? The UK policy has been that since this is a mild infection, not leading to big hospitalization, not leading to mortality, let the infection spread, let there be natural immunity. And therefore, they have allowed and they have not put any restriction, even though their cases have gone up. Because they have openly said that let it flow, as they've put it in, as their medical officer says, that we want the infection to spread because it is giving natural immunity, which is better than vaccination. On the other hand, and to some extent that is true, because this is what has been the problem which China has had. China had a policy of zero tolerance. They did not want any natural immunity to happen, and they would contain it. And they have had lockdowns in Beijing, in Shanghai, even if the cases are only about 100. So I think the policy that seems to be evolving is that you should not be that strict in terms of containment, as long as you have surveillance in place, as long as you have good genome sequencing in place, so that if it's a mild infection and you protect the high risk group, the elderly, those who have comorbidities, you may still be in a good position even if the virus spreads a little bit. On the other hand, if you have a situation where you find a cluster of increased cases which are requiring admission, which are requiring oxygenation, you must have a strict plan in place in terms of limited lockdown, in terms of contact tracing, and in terms of having a strict policy. My own feeling is that is where things would happen. In NCR, a very close observation is being done. But as you have seen, schools have not been shut. There has not been that much of a restriction. Masks have come back, but otherwise the restrictions have been limited, because current data does not show that there is increase in hospitalization or deaths. We are seeing, and the INSAGOG is reporting a higher number of cases, although the number is still not that high, because the genome sequencing is, the number of cases being tested is not that high. But BA.2.12 is the current variant which seems to be circulating and is more infectious, and therefore it may be the cause of the increased number of cases being reported in this area, because there is really no restriction. So a variant which can spread rapidly in an environment where there is no appropriate behavior will cause a surge in number of cases. But the feeling is that the surge will not last for long, and gradually, because of our own good immunity, it should come down.
So Dr. Guleria, I have a bit of comment on that. You know, in this particular wave, quite a few people say that they didn't feel so bad during the acute episode of COVID, but they start feeling unwell 3 to 4 weeks after that. And I happen to see some prominent cases of thrombosis, which occurred 4 to 8 weeks after the mild COVID illness. So if any of you have seen, this is of course anecdotal, not organized data. So, and some were associated with very high D-dimer, which had to be treated with aggressively.
So if I can,
yes, Randeep sir.
So if I can just add to that, there is some data, and there is a lot of there is a paper also which has tried to look at the utility of giving anticoagulants in the recovery period for a few months, based on risk assessment and the D-dimer value. And this is based on some limited data, which is not purely Omicron. It is related to previous waves also, which suggest that the hypercoagulable state may stay for a longer period of time. And especially in a subset of patients, it may be worthwhile to continue low-dose oral anticoagulants for at least 3 months. But I think we need more data, because most guidelines are still sort of not really clear-cut as far as this is concerned in terms of giving anticoagulants during the recovery period.
We as an institution has seen a surge in the number of young thrombotic myocardial cases to our units, and the number on the surge in the ICCU, the intensive care, cardiac intensive care, also has been seen high. But most of the times when we track back the records of the COVID illness, many of the times there was probably asymptomatic cases or a mild symptomatic cases. So we could not actually correlate or link between these thrombotic events with the any, but there is a definite surge in the young myocardial infarctions, and the thrombus pattern they were saying about white clot, not like a typical fibrotic fibroelastic plaque, but it was like a thrombotic phenomenon which was been seen in these patients. This was a cardiac team inputs at this point of time. So during this Omicron variant, what we have seen, as you rightly pointed out, we have not seen rise in real pulmonary cases. We have not seen rise in any deaths during that period, what we have seen in the previous waves. But most of the cases which actually came to our hospital for different other illnesses, coincidentally found to have Omicron or the COVID positive, and they were all been clustered into one of the ICUs, which we call the COVID ICUs. But when we retrospectively look at them, 99% of them, even only probably 1 to 5% of them had really the pulmonary involvement, what we have seen in during the Delta or during the previous waves. Most of these cases either came with a stroke and they coincidentally found, or they came with COPD exacerbation, came with coincidentally this, or a urosepsis, coincidentally found to have some COVID positivity. And this created a lot of complacency, as rightly pointed out during this period. So are we this time also, are probably, as you already explained, that are looking for a variant with a lot of things, vaccination, herd immunity and all, that we will also see a similar kind of thing, or we are looking or we are keeping a vigilant watch that we may not be 100% sure about it, the variant will be as similar to the previous Omicron one. Guleria, sir.
So that's a difficult question as to what will the next variant be like. Will it be like Delta or will it be like Omicron? I think that is difficult to predict. A lot of people say that as the virus evolves, it will become milder, and therefore we may see variants of Omicron or sub-lineages of Omicron rather than a new Delta variant, a new lineage from Delta coming up. But I think it's a difficult thing to predict, and that is why we need to be vigilant. What we've seen, and this is a big challenge that we've had in our hospital, is the Delta variant was a classical viral pneumonia wave driven by the Delta variant. The Omicron wave was driven by comorbidities. And we had a large number of admissions of people who turned out to be COVID positive, but who had predominant worsening or decompensation of the comorbidities. Chronic liver disease, going into decompensation, CKD patients, COPD patients, they did not have COVID pneumonia as a cause. And this created a problem because they got admitted to our COVID center.
True.
COVID center is being managed by critical care people who are basically looking at it from the respiratory point of view. But if you have a person who has decompensated, you also will, for example, chronic liver disease, you want the gastroenterologist or the hepatologist to be also there. So we changed our policy and we decided that we will now admit them and they would be in the COVID area, but managed by the primary unit. So the comorbidity became the predominant managing part, and COVID became secondary during the Omicron wave, which was not so during the Delta wave. And I think it's important to understand, because your management suffers. If you have a person who is being managed for COVID, which is mild, but the comorbidity, which is worsened, is not being looked after, it leads to higher morbidity and mortality. So we have started looking at now creating COVID cubicles in specialty departments. So in gastroenterology, in nephrology, in other departments, we are looking at that if you have COVID, which is mild, then you need only isolation. You don't need that much of treatment for COVID. But COVID has caused inflammation, it's caused worsening of your underlying comorbidity, and that needs greater management. So we are now looking at a different strategy as to what we were looking at in the past, where it was COVID pneumonia. But I can't say how the future would be. But what I'm trying to say is that there was a dramatic difference between the Delta wave and the Omicron wave in the type of cases and the type of management strategy that we had to develop.
I think the similar kind of pattern seen across the... Yes, sir. Go ahead.
Actually, like the hospital that I work is primarily was dedicated to liver and kidney disease, and we have large number of kidney and liver transplant patients also. Taking it forward from where Dr. Guleria said, and traditionally the hepatologist or gastroenterologist or nephrologist, they are not used to going to the COVID ICU, not even their younger people. They feel that it has to be managed by respiratory physicians or internal medicine, so they just don't go there. So obviously the care of the kidney disease and the liver disease and other comorbidities, even cardiology that suffers a lot. But I think the trend has to change. People are getting more bold now. They are realizing that COVID is not killing. So the change is coming. Thank you.
So the same kind of pattern we've seen across India, sir. Even most of our institute, when we spoke to all our friends and all those colleagues, they had the similar kind of expressions. Most of them, they turned to be positive in the ER. They came for some other reason. The primary disease and comorbidities are the reasons, but they turned to be positive COVID. And when they screened them with a X-ray or a CT, they hardly found anybody, even with a mild GGS. Very few, I think, less than 5% we had a typical the similar kind of patterns. And when we tracked back them whether they have been vaccinated, in them good percentage of them either not vaccinated or partially vaccinated or had a immunocompromised state. Very few with fully vaccinated and landed up having this extensive pneumonia, ARDS, and very few deaths what we have seen. So I hope that if that is the scenario, I think Dr. Guleria and Dr. Khilani is pointing out towards one important thing. If we now again deal with a variant which will be more infectious and less severe, then we may also see a similar kind of surge. We will continue to have flow of patients with comorbidities, and that may be killing more patients than the COVID. And that inhibition of the specialists to go and treat the primary disease, either in a surgical complication or a medical complication or a medical disorder, need to be prioritized. And this change is maybe they are both pointing out to all the clinicians who are listening to the webinar that this change need to be prepared by this time. But we don't know exactly how this variant will behave, but there is a likely chance that if it is a milder and highly transmissible, this may be again another possibility like what we have seen in Omicron. Dr. Khilani, I will just try to point out one other area, like we are talking about a precautionary dose or a booster dose. We see a good 89 crore population has been vaccinated in an effective way with fully vaccination, but this doesn't include a precautionary dose. And we very well understand more than 60 immunocompromised hosts, they do have a benefit by adding this booster dose and a precautionary dose. What is your take on that? And we also understand it is not just above 60, it is even below 60. So what is your take of giving an extra precautionary dose to the whole population?
Oh, sorry. The vaccination has been the sheet anchor of the protection against COVID. There's no questions about it. With the course of time, the initial studies, the randomized study done for 60 days, 90 days, which showed that vaccination prevents infection, were not actually found the day of, in practice. We realized that infection to very small extent protects us from infection, but it certainly protects us from the severity of infection. And Israel people were the first one. They are very aggressive with the vaccination. And whatever I'm saying is about with the Moderna and Pfizer vaccine, because less data are available as far as the Covishield and Covaxin are concerned. But we can always extrapolate that. So coming back to the point that repeated dosages of vaccination is a necessity. There was always a question whether after 3 months or 6 months or 9 months, nobody actually knows. But over a course of time, the Israeli people, as I said, they were at the forefront. When they gave the booster at the 4 months, they showed with the data that infection rates came down and also the mortality goes down. So therefore, my thinking is that this 9 months of gap has been given because of the logistic reason. The correct gap between the second and third dose could be 6 months or 4 months to give the most appropriate immunity and the protection. There's no question about it that repeated dosages of, or you call it booster, or you call it precautionary dosage, would be required to sustain the immunity level so as to minimize the severity. The data suggests that the vaccination gives protection from the death to the tune of 85%, which is actually very good. So it doesn't give protection against 100. We saw during Delta wave, some of our doctor colleagues, unfortunately, and the healthcare workers lost their lives when they were actually doubly vaccinated. But the final, my take is that repeated vaccination or booster is required. My personal thinking is that 6 months is the ideal time. If I talk about the science, 9 months is equally good, I would say. Thank you.
Dr. Guleria, this raises a very interesting questions to all of us. We all got our the precautionary dose 4-6 months back. It varied between last year. So is it will be a routine phenomenon like what we see in influenza with drift and shift, that we need to probably take a jab intermediately depending on the variant or immunity? What do you foresee this kind of vaccinations to go on?
So two things. One is that I definitely foresee that we will need to take precautionary dose or booster dose frequently, at least for some time in the near future, till we get a better hold of how the virus is behaving. And the duration can be debated. Ideally, it should be between 6 to 9 months in my mind, and therefore we need to keep that in perspective. The second issue is who needs it. Should it be the entire population, or should it be the high risk group and healthcare workers? Healthcare workers and frontline workers, because they are the force that is needed and their exposure is high. And the elderly and those with comorbidities, because they are having a chance of more severe illness. But is it required for all healthy young people or not? And should it be given across the board to everyone or not? I think we still need more data as it evolves to say that, but definitely healthcare workers, elderly, and those with comorbidities do need to take booster dose or precautionary dose and may need to take it more frequently. We need more data as far as the younger generation who are healthy and who probably have had the infection naturally and have some degree of hybrid immunity. We need more data as far as that is concerned. The second important issue is, what should be the ideal vaccine? Remember, the current vaccine that we're giving is against the Wuhan strain. We have moved on from alpha, beta, gamma, now to delta and omicron. And we know that for influenza, we have a new vaccine every year, which looks at the new circulating strain when there is an antigenic drift. And currently it's a quadrivalent vaccine, which covers 2 influenza A and 2 influenza B strain. So in the near future, should we have a polyvalent COVID vaccine? Should it cover more than one strain? And there are studies which are looking at vaccines which are covering, say, the Delta and the Omicron, and could be given as a bivalent vaccine. So the future would actually decide as to what should be an ideal vaccine as far as the new generation vaccines are concerned, which should cover the newer variants, because as the vaccine, as the virus evolves, the older vaccines that are currently being given may cause more and more breakthrough infection. Current data is ambiguous. There are some studies which suggest that even in some limited data which was there, that even the Omicron vaccine, which was given to some, caused breakthrough infections to happen. So I think we need to get more data, which is evolving. There are a number of studies being done to look at a bivalent vaccine and to look at new generation vaccines, which are already in trial phase. And possibly because of the fact that we now are more comfortable with the platforms that we've used in terms of getting the emergency use authorization, it will happen at a much faster pace. And there is also data which is looking at, can we combine the influenza shot with the COVID shot? So there is a study which has given influenza vaccine and the COVID vaccine to the same person on the same day on different in different arms, and shown that they are equally causing a good immune response. So in the future, you may have annual influenza and COVID jab combined into one. So these are things which may evolve over the period of time. So I think it's important to really, at this point in time, say that we are going to need booster dose or precautionary dose, especially the high risk group and healthcare workers. And also we should look at research into new generation vaccines.
The cross vaccination, same vaccination. At this point of time, India follows the same vaccine, but we do have probably the cocktail vaccines also. Khilani sir.
So yeah, so whatever the evidence is now, so far so good. You know, whatever vaccination has been given, as I said, more data is for mRNA vaccines. The protection that this vaccine has given has been good for alpha variant, for delta variant, and also for Omicron variant. But as Professor Guleria said, we don't know. whether it will be effective against the next variant. Initially, the virologist said that especially Moderna and Pfizer vaccine, they'll be able to give us a new vaccine, or you can say the vaccine which is focused on the particular variant within 3 months. So far, it has not come. But thankfully, the original vaccine is giving protection against the severity of illness caused by all the variants which have come so far. But in the future, we have to see how it goes.
Dr. Guleria, we are now opened up schools. You're saying physical schools are on. And also we are talking about the kids vaccination. And now we rolled out in India between 6 to 12 and Covaxin is on place. So how do you see, there are many families calling us back, many primary clinicians looking at both of you, Dr. Khilani and Dr. Guleria, to get their answers that the families call back them. The kids are yet to be vaccinated or just vaccinated few weeks back. Should we send our schools to physical attendance? So this is being a common question many clinicians face. So they wanted to listen from you. Guleria, sir.
So I think there are 2 or 3 factors which should reassure parents. One is the fact that if you look at the sero survey data, which was done in children itself, it showed that a large majority of children in India had the infection and were having good antibodies naturally. So it shows that children usually get a mild infection, they recover, and therefore they are protected by natural immunity. Secondly, if you look at admission that we've seen, and we've collated data from our hospital also, during the Delta wave, during the Omicron wave, we've not had children being admitted who are healthy with severe COVID pneumonia or infection. Majority of children who were admitted, I would say the vast majority, for those who had comorbidities, children who were on chemotherapy, children who were on steroids, or children who had other immunosuppressive diseases, they were the one who got admitted with more severe COVID infection. So I think we must really look at the data and be reassured that children by and large are having a mild COVID infection, and we're not seeing that type of severity that we're seeing in the elderly or in the older age group. And now that the vaccine has been rolled out, it's important that for parents to be doubly sure they should get their children vaccinated, and that will also help. One of the concerns that one had in the beginning was that children may get a mild infection, but they may carry the infection to their homes and then give it to the elderly or people with comorbidity, and that may cause severe infection at home. Now, there is again conflicting data in this. There are some studies which support this. There are certain studies which don't show children to be good carriers and have not shown cluster development even in this. And we have had a detailed discussion on this in our national task force, couldn't come to a conclusion. But I would say that parents should be reassured that their children will, if they get COVID, will only have a mild infection. Vaccination is now available. They should come forward and get their child vaccinated. And I think physical schools are important, and therefore they should continue or should send their children to physical schools.
So there are some interesting audience viewers questions here, sir. Sir, when you emphasize that the management of comorbid condition and creating a COVID cubicles in the specialties should be a part, what we have seen in Omicron, if the similar kind of pattern we see in future. So can you please incorporate this kind of guidelines in when we actually come up with the COVID guidelines in the next way, because that's where the many primary clinicians are looking at and that. So your take on that.
I agree with that. I think it's important. I'll try and see what we can do. We've tried to do that in our hospital because the guidelines have to look at infection control. Management of COVID is not that issue, but the cubicle cannot have the central AC in being given, supplying the ventilation there and into other areas. We know that there can be aerosol transmission. So infection control, both in terms of ventilation, good cross ventilation, in terms of PPEs, in terms of the preventing infection from spilling over from that cubicle to other areas. Those practices have to be kept in mind, and those have to be implemented. And this is what we're doing, because this needs a little bit of restructuring of the hospital ward or the cubicle that you dedicate. But it's not too difficult. Most of our centers have managed to do it. We have a cardioneurology center, a CN center. They have created that. Our main hospital has created one area in the 6th floor. The cancer hospital has done that. And we've tried to look at it from the infection control practices, got our infection control team to get involved and develop a strategy for each area. And that can be something that can be practiced in hospitals. The management strategy is not very different. It's mainly symptomatic support. But you have to make sure that the infection control practices are aggressively followed and the staff there is properly trained.
Probably they are looking for a guideline for that for individual unit, maybe.
I'll try and tell our
Yeah.
hospital infection control team
I
if
think
we can
it's,
make a small.
yeah, so for a
package.
dialysis unit, for a cath lab unit,
Yeah.
a cardiac unit, that thing. Khilani sir, there was another interesting comment that as now we are taking the precautionary dose and we all understand, now at least we have some immunity to protect us. And also there is again a trend, sir, the initial way when we dealt with alpha, beta initially, we know formites contacts being a major concern. And later on we realized that more droplet and whatever the debates related to droplet between airborne, and we took the precautions of mask being the primary modality of protecting us. So the questions are, should we drop the PP kits, the lot of PP kits which has been used during that first wave, second wave, sophisticating the whole set of things with lot of gloves, double gloves, triple gloves, which created more number of infection than protecting us. So Dr. Khilani sir, what is the take on that?
So I don't think you have to drop the PPE kit. You can't go overboard on that. As far as the COVID facility is concerned, just because the Omicron wave has been a mild and people are not dying, the pneumonia is not there. There's no guarantee that the next variant will be of what kind. So therefore, there's no question of dropping the PPE kit. And as Dr. Guleria has said, in fact, we should be more stringent with the infection control practice, and PPE kit or gloves. Only thing is that we have learned a lot. Initially, if you remember, Venkat, when the first wave came, we were so skeptical about giving nebulization. We were so skeptical about using non-invasive ventilation. We were so skeptical about doing this, even high flow nasal cannula, that the flow should be less. Over a period, we learned that if we follow the infection control practices, the transmission can be, may not be there at all. So therefore, what you are saying, I will go reverse. That infection control practices, including the PPE kit, should be as it was done in first and second wave. It should be followed strictly. Air circulation is extremely important. It's very easy to carve out, like this time in our hospital, when this third wave or whatever you call it was coming, we got prepared, and the engineering section had to go in overdrive to segregate the air conditioning system of that area absolutely separately. But all those things have to be followed. We don't have to lower our guard as far as the infection control is concerned. Thank you.
So there was another interesting question, Dr. Guleria, that genome sequencing, that has been prioritized by all of you being in the top lead. So INSAGOG again earlier thought of actually doing the sequencing more frequently. Is that functional? How important is it? Now, as you said, we need to keep a very vigilant, close watch on all these areas. So sequencing and knowing the variant, how important is it right now?
It's very important because in my mind, and this is something that we are pushing for a lot, that not only genome sequencing, linking the genome sequence data to the clinical and epidemiological data is very important. You may pick up a new variant, but it is a variant of interest or is it a variant of concern will be decided as to how you're seeing the cases and what is happening in that area. So you may say that we have a new variant. We picked up the double mutant, which was the Delta variant, but it took us a long time to really link it with in the surge in cases and the higher mortality. So you have to be really on it from the very beginning, and therefore the data has to flow together into one area where it can be interpreted, where you're looking at genome sequencing, you're looking at the clinical cases being reported in that area, you're looking at hospitalization, and you're looking at the disease pattern. This is what is being done in the ministry, and the INSAGOG data is every week fed into the database. They have a large dashboard where the clinical data also flows in from NCDC and from the IDSP. And from the same data, there is also data from ICMR in terms of number of cases being reported from different sites. So I think that is something that has to be built up. And currently what is happening is that we started off with 10 labs which are doing genome sequencing. We have now almost 40 to 50 labs, both in the private sector and in the government sector, which have now been linked. And so the plan is to have a surveillance network which will be able to do surveillance for ILIs. It's not only for COVID. It will be a surveillance for influenza-like illness, so that you can later on pick up any influenza-like illness, whether it be COVID, whether it be H5N1, H1N1 in the future, and be able to link that with your clinical and epidemiological data. Because I think we may see this pandemic come down, but it's not the end of the story. We have to be prepared for the future. And if we're investing in this, we must have a network in place, both for genome sequencing and for the data coming in. And that is where one is pushing for, and hopefully that will happen.
I think the many clinicians who are when they're listening to you are trying to learn from you that if I see a cluster in city of Hyderabad or somewhere around, and I suspect a new variant to come up. So for a genome sequencing, how do you proceed? Suppose you said BA12.12 is now what is been seen there. So if I suspect, how do you channelize from a city?
So there is an SOP for that. And the best thing is to contact NCDC, which is the nodal area. They will tell you the nearest lab where genome sequencing is being done. They will also send what is known as an RRT, a rapid response team. So if you report a cluster, a rapid response team will come and do an assessment and see whether that area needs to be declared into a containment zone, whether the sample needs to be taken, more sample needs to be taken from the contacts, and genome sequencing would be done. So that is an SOP which is in place. But the NCDC, the National Center for Disease Control, is the nodal center. And the best thing would be to talk to them or to send a mail if any physician notices a surge in number of cases. And this has really helped. If you look at what happened in the South, forget COVID, we had an outbreak of Nipah virus.
Yes.
And the Nipah virus outbreak was actually reported by a doctor in a private hospital.
Yes.
He saw a cluster of families happening. He contacted authorities, and they were able to do very aggressive containment and control the outbreak of Nipah virus. So if that can be done, we should be able to do it for any cluster, for any infection that we are seeing. And that is why I was saying that we need to develop a surveillance network which is broad-based, which covers more than just COVID, because we could have an outbreak of any other viral infections. And we must have a system in place so that we don't really land up like we did in the early days of COVID-19.
We have Dr. Pawan. Dr. Pawan is the director of Yashoda Group of Organizations. Sir, he happens to, we are fortunate that he happens to be a clinician, a postgraduate in medicine, and then he went through both critical care and pulmonary medicine in the United States of America, came back and now shouldering the organization on his shoulders. And he was so glad and happy that now we are talking about a national guidelines, uniformity, and this has been a phenomenon in this last pandemic. I think there is a change in the field of medicine where the uniform protocol has been circulated into many of us, either looking at All India Institute of Medical Sciences or Dr. Khilani says many updates which came up. So I request Dr. Pawan to probably be a part of it. Dr. Pawan, over to you.
Yes, thanks, Venkat. I'll just add a quick one. Sorry, I wanted to log in before, but in meetings now in my other hat as an administrator, managing doctors is taking a lot of time nowadays. But thank you, Dr. Khilani Sab, and thank you, Dr. Guleria, for coming online and sharing everything. And I met you personally also, and I feel good that the country is in great hands now after the first, second, third, and even if you have the fourth and fifth wave or whatever, we are in good hands. So medically, maybe I'll not be able to contribute too much nowadays, mostly in the administrative part, but it feels great to have all the great people in one platform to get. I think this one problem with this in India compared to US is, as you said, rightly said, Venkat, standardization is slightly missing. Treatment maybe protocols is like varying widely depending on the hospitals. But now with all this interconnectedness and great work with leaders like you, we are getting there. And thank you for your efforts, both in the first wave, second wave, third wave, and also future also. Your confidence. So I think I just want to say that glad to have all of you, and we'll continue to make a uniform guideline so that benefits everywhere everybody anywhere in the country, wherever they are. Thanks.
Yeah, thank you, Dr. Pawan. It was such a pleasant experience, sir. I'm humble. I'm thankful to both of you, Dr. Guleria, sir, and Dr. Khilani, sir. And when I just called you, I got hundreds of calls that to thanking both of you to be available for this webinar and share your wisdom. See, we may go through those protocols, but when we hear it from horse's mouth, and when you both share your experiences, that means a lot to all of us. And we thank both of you for your time and in this video schedules. And I thank Dr. Sai for his brief through the fourth wave overview. And I thank all the participants who have been very enthusiastically putting a lot of questions. So we hope we bring similar kind of sessions in the future. I thank both of you, sir, and I conclude the session. Thank you, Guleria, sir. Thank you. Thank you, Khilani, sir. Thank you, Dr. Pawan, for those opportunities and encouragement.
Yes, thanks to everybody.
Thank you.
Thank you.
Thank you, Guleria, sir. It's
Thank
a
you, sir.
pleasure and kind for you.